the recording. Welcome, everyone. Today is Wednesday, March 12th, and 2025. This is the PACIO weekly meeting. On our agenda, I will provide the leadership update, and for that, there will invite our subgroup lead to provide the subgroup activity updates. And follow that, we'll have a PACIO US CDI V6 draft comments discussion. Will be led by Wuba. All right, any question before I get started? Yeah, on behalf of Kelly, I think probably we should just do a quick introduction about the PACIO project and what we do when it started. And we have our monthly meeting, which is supposed to schedule for next week. And during that meeting, we go through the depths of our community, what is PACIO. And with the consideration of the time allocated, I probably just go through this slides really quickly and the PACIO stories, and we want to address the key healthcare challenge like the poor communication and the medication discrepancy and the redundancy information collection during different settings of the patient's health journey. The PACIO project started in February 2019. It is a collaborative efforts between industry, government, and stakeholder. We aim to develop a FHIR implementation guides to enhance the health information exchange and interoperability. So the PACIO focus on creating framework for data exchange and across care settings, and we have focusing on several use cases, and there are 4 active IG, and the quality measure is the use case we hope we can explore in the future. So we are this is a PACIO use case and the timeline, and we are all moving toward the right directions. And the ADI and the personal functioning engagement, the transitional care, standard medication, that's the 4 active IG I mentioned in previous slides. So I think that's a whirlwind introduction, quick introduction to PACIO project. And I invite the people attend the PACIO monthly meeting next week to learn more about PACIO project. And additional, we have a PACIO project web page and Confluence page, and there are lots of resources. And reach out if you have any question. Then go back to our PACIO leadership updates. So there is no updates, no change on the communication path, and HR7 path is still going on. But PACIO community, we have been updating the HR7 Jira and Confluence page, and although HR7 is still under communication path, but our IG development still pushing forward, and we are attending the work group meeting. There is no, we are still targeting our balloting and also different activities. So our IG development, the PFE functioning and engagement IG is wrapping up the ballot reconciliation, and it is going to apply all the change approved by the PACIO community, and it's targeting to publish the STU2 IG in early 2025. Transition of care, we are targeting balloting and May balloting, and the IG is in HR7 repo now, and their team is working on the first initial draft of the IG, and the team will be presenting to their patient care work group tomorrow, and we hope we get approval from the work group. And standardized medication profile, the IG has been approved to publish because HL7 PAS, communication PAS, it's not visible to the public yet, but it's on the way to get published. And the Advanced Directive Interoperability IG, we are targeting the September ballot, and the team is working on the JIRA tickets from the balloting process and exploring additional concept and consolidating the IG. So this, including the TOCIG, including the link here, it is now red instead of purple, so it's official, and we are very excited for the IG to move forward. And additional updates. So upcoming conferences, and we have several PACIO community member to representing PACIO to present in the National Academy of Practice annual meeting, which is in Washington, D.C. in March 13 to 15, which is just this weekend. And we are also preparing to attend the American Nursing Informatics Association annual conference. And the poster is accepted, and the PACIO team is recording their poster. And in addition, in the EMEA 2025 Clinical Information Summit, and the PACIO poster has been accepted and will be the PACIO team member will be presenting on May 2020, May 20th to 22nd. So because the HL7 communication pause and the CMS communication pause, and it's kind of has an impact on the PACIO, at least the MITRE team and the CMS team's attendance for their upcoming conference. But we really appreciate our community members that up and participating and join the meeting on behalf of the PACIO conference, and we'll be reaching out to the community member to, if you know any particular conference opportunities, and definitely let us know, and we'll help submit the abstract. And as a community, we want our presence in the different conference. And I think in Cali's page, we definitely feel like the interest has increased after the HIMSS, and we appreciate our community, the PACIO community member, spread the words during the conference, and that's really valuable for other people to know PACIO's work, and then we want to increase our impacts. That's the leadership updates. Any questions? Any comments? All right, hearing none, I will pass the ball to Maria to provide the updates for the ADI subgroup.
Great, thank you very much. So let me share the report out deck. Excellent. So we just wrapped up our Advanced Directive Interoperability community meeting. We had a review of US CDI Draft V6, and we really got a lot of feedback on the data element of portable medical orders. And so we crafted some language that examples of those portable medical orders, could be a POLST, a MOLST, a DNI, an EMS comfort care, an out-of-hospital DNR, just really proposing that the current description that is there, which refers to structured data, and the rules of engagement with USCDI are, if you don't have an IG that you can point to, then how can we possibly promote a data element with no rules of engagement to follow. And so the ePulsed CDAIG has some issues that we know of, and it was built for one specific form where we have over 86 forms in our environmental scan. And the ADI with Fire STU2IG, which focuses on PMOs, is not yet published. And so we understand those rules of engagement. So what we did is we crafted an alternative description, and I just reviewed this with the ADI community. That description would be modeled from the Advanced Directive Observation data element, and it is more general in context. And the language says that a provider authored portable medical order document would indicate its content, location, type, verification status, and that this would apply to structured or unstructured data, the type of portable medical order, where it can be found, whether it's been verified, because we have confirmed that within US Core, the ability to exchange unstructured documents already exists, and further, that they have the Advanced Directive Interoperability document type hierarchy. So the highest level is a general document, and below that, you can further indicate, oh, this is not only an Advanced Healthcare Directive document, but it is specifically a living will, or it is specifically a durable medical power of attorney, or it is specifically, a portable medical order or a DNR or a mental health advanced directive. So we know that we can point to US Core and CDA. That would be the IG that we point to. So we had to soften the language to accommodate unstructured and structured documents. And we use that advanced directive observation language to help us. And that really helps us to meet the industry where they are, because it gives vendors that have hundreds of thousands of these forms in their EHR the required IGs to point to in order to make them available. And so I'm going to clean up the language on that, send that out to the ADI community. And then when we meet week after next, we're going to gather their comments and get that finalized. We also reviewed what you guys have been talking about related to the provenance data class and the new data element, purpose of capture. And we really feel, especially in data elements like treatment intervention preference or care experience preference, the purpose of capture would be a perfect data element to attribute to that type of concept, so that the receiving clinician could really see, oh, well, that treatment intervention preference was captured. The purpose of capture was a high-risk surgery. And so there's no document to point to, but this is what we captured in the notes. And so that purpose of capture would be a really helpful piece of information to attribute existing US CDI data elements. So we talked to the community about the ADI with Fire STU2IG not being published before they finalize V6. And we helped them understand that we've done our homework and our due diligence, that the core US Core Fire IG and the core CDAIG really allows us to move this data element forward, even if the document is unstructured. And we asked them if they agree. And then, they came back and said, hey, well, we get all of that, but we don't want to lose versioning, right? Because that's part of the really important metadata that helps to prevent adverse events that might result from different versions of a portable medical order being used when one is outdated or superseded and there's a new current. So the group said, yeah, get portable medicals in there. Keep going, keep pushing. The faster we get them implemented, the better, even in an unstructured form. And then we reassured them that the metadata that encapsulates an unstructured document, whether CDA or Fire, that reveals versioning. And so they said, great, yep, objections sustained, we're good to go. So we then moved to the environmental scan, and we talked about some outlier type concepts. There's one source form that allows capture of consent by patient to allow their healthcare agent to modify or revoke their post in consultation with the treating practitioner. And that's a different twist to concepts that we know of. So we described to them how we propose to handle that. And we talked about another source form that allows consent of the medical power of attorney to make decisions and create a new form in accordance with their express wishes. Again, that's different than this, which is different from an existing concept. And we said, look, there's a permit provision in the consent profile that we can use to address these two deviations. And so they said, yep, that makes sense. And then there was another concept on expressing decisional capacity. There is a really common LOINC code. Most LOINC codes are like 5 digits dash 1 digit. This one is so old, it's 4 digits dash 1 digit. And it's very well known. And it has to do with mental capacity. And unfortunately, at the current time, there are 216 different answers because it's so widely used. We're going to go through those 216 answers, and we found about 12 that are appropriate for the ADI use case. And we will bring those back to the community and share with them how we constrained that value set and get their approval and buy-in. So really, really productive 1-hour session. And boy, I'm sure happy to entertain any comments or questions that this community might have. Well, I guess we will. Yes,
Maria,
sir.
hi, this is Terry. On the capacity to make decisions about care, does that extend to capacity to indicate how information can be used, could be used? So decision-making capacity around treatment versus around information sharing.
Oh yeah, no, that's a good question, Terry. In the So the concept is called mental status. Well, yeah, like every doctor out there records mental status as you're visiting with someone, right? So that's a very broad utilization. When we looked at the responses, there are about 12 of them that deal with the patient has decisional capacity in my expert judgment. I don't think it's specifically dealt with treatment decisions, but we know that the express permission to exchange information can't be expressed in mental status. So we've had to split those two apart. And I will be reviewing the short set of answers with the PACIO community because, gosh, you guys do cognitive status and all kinds of stuff all the time. And again, we had to really narrow it down to decisional capacity. So I can think of a behavioral health use case, right? So when I'm doing my mental health advanced directive, sure, there are certain conditions and issues that I may be experiencing, but do I have decisional capacity is just a really narrow subset of mental status. And so that is the area that we were focused on to represent something in a couple of forms. Was that down a rabbit hole or did I answer?
Yeah, it sounds like it's a murky issue and one that is not at all clear in US CDI. So kudos for taking it on.
Well, all you can do is dig it out and put it through ballot and let everybody shoot holes in it. And if they've got a better idea, that's what ballot is about. So we felt pretty good about this from the feedback we've gathered so far. But I will look forward to presenting it to you guys in a couple of weeks, and you give it the smell test.
Maria, this is Trish Salibi. I have a question. When you said there's like, you narrowed it down to 12, are you talking about things related to like the like the code of patient with decision-making capacity? You're not talking about like if there's a court-appointed guardian, for example, or a legal surrogate. You're talking about things. Right, go ahead.
No, you're 100% correct.
Okay.
So our greatest joy has been to take 87 existing portable medical order forms in use across the US and break those puppies down into individual Lego concepts. And boy, what's so easy on paper is a feat in the world of digital data exchange. So there's just a checkbox. Check. Patient has decisional capacity. Oh my gosh. Well, that's great to check a box, but now we've got to go find a way to express that in machine terms, and the current mental status term has hundreds of answers. Well, I don't need all those answers. I need a way to express that the box was checked, that the doctor says they have decisional capacity. So I'm trying to narrow those 216 down to just a few answers for this express purpose. Did that help?
Yes, thank you.
Thank
That's
you.
all right.
Yeah, thank you very much, Maria, for your updates. And I think for the US CDI comments, definitely the PACIO community want to support the ADI community's comments. And for today's US CDI V6 draft discussion, and we are going to ask the community to vote part of our PACIO comments, but we want to give the community enough time to review the PMO and provenance related comments. And we can revisit that with a second vote because we have time to do that until April 14th. Very impressive work, Maria. Thank you so much.
Oh gosh.
Thank you. Thank you. Next on our agenda, we'll have Jamar to provide the PFE subgroups updates.
Okay, thank you. So in the PFE meeting today, we had really good conversations, and the conversation focused around ordering equipment and reimbursement. So a week or so ago, Uber, Brian, myself looked at a lot of existing profiles to things that the group decided that we should look at addressing in STU3. And one of those things was ordering equipment and reimbursement, so capturing items that would support reimbursement as well. So we found an existing profile that CMS had actually used in some of their documentation and went over that with the group. So what was there, what was missing? There were several things that we thought would be good to add, especially to support from a reimbursement perspective, like some procedural terminology, CPT codes, HCPCS codes, ICD-10 codes, and other things more specific to PFE as well when we're looking at ordering equipment. For example, cognition, maybe preferred language, vision, all those things. So we are going to continue to look at that, and the next meeting, hopefully we will be able to address behavioral health as well. But that's what we did today in our PFE meeting.
Thank you, Jamar. Any questions for Jamar? If not, and so Terry, you are here. I provide the general quick updates for TOC subgroup. Do you have anything you want to add?
Just that James has been working well to get our consolidated data set. We now have 7 role groups who have come to consensus about what their essential elements are. And James is consolidating that and also taking the non-Dell items that each group has identified as being essential and compiling those into a list we can harmonize and make sure. But we're making great progress. This will be ready to roll in the next week or so, and we'll plunk right into the IG as it moves forward. Thanks.
Awesome. Yeah, thank you, Terry. All right, that's wrap up our subgroup update. Let's move on to the next.
Can Can I
Oh,
just ask one question?
yeah,
And I did put it
go
in the
ahead.
chat.
Go ahead.
Sorry, this is Bob, and I did put it in the chat area as well. Terry, I was just trying to find out, are those data sets available on the site? Can we go in and look at them yet?
Good question. I don't know if they're in, I don't know where they are in box, but it asks, they should be ready for release pretty soon. I mean, within the next week, I would expect.
Okay, I can wait till then. I wasn't sure if they were. Thanks.
Okay.
Thank you.
Yeah, they are on box, and if you cannot wait next week, Bob, and we can share the box link to you.
Perfect. Thank you.
Sure, yeah. All right. So Uba, do you want to take over? I can share my screen. Uba, if you're talking, you're on mute.
Hey, can you hear me? Can you hear me now?
Yes.
Okay, great. Okay, so thank you so much for sharing the comments. What we're showing you now is an updated set of responses for the draft USCDI v6. You all looked at it previously, and based on the comments that everyone gave, the internal team made updates to include those comments. And at this point, we're just going to be reviewing the updated data elements and to get your vote to submit them. And so we won't be, since we already got your feedback, everything should be fine. We just want to get your okay to submit these. But if you see something that's glaringly omitted or something that really needs to be updated, please let us know. But hopefully everything should be ready to go for everybody. So we'll start first with the disability status data element that's at the bottom of the first page into the second page. And we'll just give you a minute to look it over.
I guess you have to be a fast reader to to read all those. But yeah. Yeah, I'm trying to scroll the screen. Hopefully, if you need more time, let me know.
May I ask a question? This is Kelly or Ben
Yes.
again. Just for this review of the USCDI version 6, can you just give me a high level on what it is that we're trying to achieve with adding or removing the language from the USCDI? Is it that we're looking to have our own USCDI kind of post-acute version, or is it, what are these recommendations based on?
So the recommendations are based on, in general, across all these different data elements. It's a combination of making them more inclusive of PAC settings. Some of the data elements are very oriented towards acute care settings. And so sometimes the data elements that we'll be going over are suggesting an expansion of a definition or expansion of what can be considered for that data element to make it inclusive of PAC settings. Sometimes there's a recommendation to remove a data element because there's another data element that already exists. And in order to help eliminate duplication and streamline what's available and make it easier for folks to document a specific concept, So when there's a recommendation to remove a specific data element, it can be because of that. The other reason why a data element can be removed is an example here where the current data element is not sufficient, and creating a simplified and more inclusive version of the data element is being recommended. So here for disability status, recommendation is to remove the disability status data element that already exists, that's in the health assessment data class, and recommending instead to bring in this new data element entitled disability to the patient demographics. And the rationale that was developed here was based on community feedback during PACIO meetings, and that includes feedback from this group as well as feedback from the individual subgroups. So there's the advanced directives subgroup, there's a personal function engagement subgroup, there's the transitions of care subgroup, and then the standardized medication profile. I'm not sure if they're still meeting, but all these different groups also were collecting feedback. And so getting feedback from community members who are experts in these areas helped inform these recommendations, as well as the internal team's research into what are the current standards of use of these data in practice settings. Are there recommendations by CDC, CMS, other organizations to capture information in a certain way? And so pulling together all those lines of evidence is what informs the rationale. So does that answer your question?
That absolutely does. Thank you so much for providing that information. So once you have all this together, do you submit the rationale, or just do you submit it to the Office of National Coordinator for Health Information, or the ONC, that here's our recommendations for the USCDI and how they take that in consideration? Where do you send it to?
Yeah. So if you go to the USCDI website, you'll see that in past cycles of comments, there's a PACIO comment that's posted on the website, along with other organizations like CMS, CDC, and then individuals also post there as well. So that's where we'll be submitting comments, unless Yolanda, there's been a change I'm not aware of.
No, I think you're right. It is just ASTB has ONC has a formal submission process, and PACIO submit those comments as a community.
Yes.
Wonderful. Thank you again. I appreciate it.
Yeah, of course. Yes. And so if there's any other questions about the process, just let me know. I'm happy to provide any additional information. So then
I just wanted to add. Sorry. Go ahead, Pat.
This is Trish Leby. Well, Kelly's questions prompted me to think perhaps we could have some sort of like a little bit of a informational session onboarding as we start to promote this. It might be good to add something like that. Like maybe it's like, so it's not in the actual meeting that we're having, but maybe something, I mean, I hate to add another additional thing, but something that could be spread out to like our wider community that want to get to know about the PACIO and the process. It might be good. And it could be something that could be recorded, which we usually record everything, and then made available, to like a greater audience. So just an idea as we keep getting more and more people, which is great, involved in the project.
That would be great. Thank you. I'll bring it back to the group, and we can figure out a way to do this PACIO 101 onboarding. We've talked about it before, but this talking about our USCDI commenting involvement hasn't come up yet. And PACIO submits for every cycle. So that's, yeah, it'd be a good thing to find a way to do exactly what you recommend. Thank you. Is there someone else who had a comment or a question? Okay.
So, Uba, I have a suggestion for each of the comments. Can you just, instead of asking you to be able to read the whole thing, can you just do a high level summary of what PACIO's recommendation for each of the?
Oh, sure. Yeah.
Yeah. Thank you.
Sure. Yeah. Yeah. So for the disability status, the high level overview of the rationale is that disability status is more useful in the demographics section rather than as in a health status assessment, because disability does not necessarily equate to a health outcome. It's related to it, but it's a higher level characteristic of a patient, and it might not be the reason why a patient goes in to seek care. So that's why there's this recommendation to remove it from the patient demographic, or from the health status assessment to patient demographics, and simplify it to disability as the name of the data element. So any thoughts about this one? Or does anybody oppose going forward with this description? Okay, so we can move to the next one, which is functional status and mental cognitive status data element. And the recommendation is to expand the definitions of these data elements to include ASHA's FCMs that have been assigned LOINC codes. And the rationale around this is that the FCMs are they're the discipline standard for speech, language, and hearing assessments. They're part of NOMS. It's recommended by CMS, and that this would help with transferring information about functional status and mental cognitive status information, especially in PAC settings when there's assessments that are done by speech language pathologists. So expanding here, it's expanding the current description to be inclusive of FCMs that are assigned LOINC codes. Does anybody disagree with this recommendation? Okay, we can move on to the next one, which is for the functional status, health concerns, and mental cognitive status data elements. And the recommendation here is to expand what's already there to include the International Classification of Functioning Disability and Health, the ICF, which is developed by the World Health Organization, as an applicable vocabulary standard to these data elements. And this is part of a larger, this is part of a continuation of PACIO recommending ICF, which it has done in the past for data elements, and PACIO has included ICF in implementation guides developed in collaboration with the PACIO community. And the ICF is recommended or endorsed by several organizations, including the National Committee on Vital and Health Statistics, the American Physical Therapy Association, and ASHA. Even though there's not clear information about whether or not they endorse it, they provide, ASHA provides information on using ICF. And as I had said before, PACIO has already integrated the ICF into existing implementation guides. So that is the rationale for this recommendation. Does anybody oppose going ahead with this recommendation? Okay, we can move on to the next one. The nutrition status data element. So the recommendation here is to advance the nutrition status data element from level 0 to level 2. And just as a reminder for folks, or a primer for those who don't know about the different levels of that data elements can be assigned to, data elements in level 0 don't have a lot of, they don't have their use in widespread use in clinical settings, and are not regularly exchanged or included in implementation guides. And we are recommending moving it to level 2, in part because not only is it really important, and this is information that's already included, but also the PFE, personal functioning engagement subgroup it has right now in SQ2 nutrition order data element that that's related to this nutrition status data element. And this is, so overall, the rationale is that this is information that's routinely collected by nutrition specialists, and that this is really important for patient safety, health, and recovery, and is really important information to support clinical decision-making across all types of health practitioners. So does anybody have any, does anybody not recommend going ahead with this this recommendation as written? Okay, we can move on to the patient communication. So the recommendation is to advance from level 0 to USCDI v6, renaming it to patient communication and moving it to the patient demographics. And the rationale is that this is really important information to effectively and accurately receive information in regards of the patient. And this is really important for medical decision making, and not only for the clinicians, but for the patient to be able to express their wishes and goals to the clinician. And right now, USCDI doesn't currently capture whether a patient overall can communicate effectively. And therefore, this information needs to be included, because current data elements do not provide enough information to healthcare providers about overall communication ability. So does anybody have any reservations about this this recommendation as written?
Hey, this is Lorraine. I guess I'm just not totally 100% on putting it underneath patient demographics, but I'd have to.
Mm-hmm. Okay.
I guess.
What's your thinking behind that?
I guess demographics, I think, are totally different than like a functional thing or a physical assessment, right?
Mm-hmm.
But I don't know, I have to look at this a little bit more, the rationale, and then where it makes it in another class, a data class, as opposed to demographics.
Yeah, it seems like under the health status assessments, there are a number of different statuses. So, and again, these data classes are just grouping concepts, but maybe to Lorraine's point, it could go under health status assessment, maybe instead of demographics. It almost matters differently where you put it, but maybe to her point.
Mm-hmm. Okay, so overall communication ability you're saying would fit better under the health assessment. I guess the thing that this data element is trying to is slightly different than the outcome of an assessment about, whether or not a person is able to communicate verbally, for example, this is more of like a holistic data element about communication that is based on that could be based on multiple assessments. And so that was what kind of led towards including it in the demographics rather than an assessment which would provide specific information about what are the communication deficits. Like there's some speech impairment, like a specific speech impairment that's found during an assessment.
And then this is different from the needing an interpreter, right? Which is already in the core.
Mm-hmm.
Okay. All right. Okay.
Yes. Yeah. Like needing an interpreter or like preferred language. This is different from that, and like a more global communication if they're able to communicate.
Yeah, but if you look at the description in USCDI of health status assessments, and you're going to capture communication status as a part of an assessment, it says, assessments of a health-related matter of interest, importance, or worry to a patient, patient's family, or the patient's healthcare provider that could identify a need, problem, or condition. Mm-hmm. So isn't that what patient communication assessing that would reveal? Oh, there is no problem. They communicate just fine, or they're nonverbal, or, it seems less demographic-y because that's like what goes on the claim as opposed to what you might assess for and reveal. But I'm just looking at it from a data stance. Y'all are the SME.
Yeah. Oh, that's all good. Yeah. I guess. Oh, go ahead.
Go ahead. No, I was just going to say demographics. I feel like that's more of like an intake and this administrative information. Not that is, but medical records, sex, or insurance, paid, all that kind of stuff, as opposed to some kind of assessment, or not that it can't be, but and again, these are data classes, right? The classes don't matter as much, but to me, logically and clinically, it makes more sense to be in some kind of health status or demographic.
Okay. So I guess then the question would be, would the various different types of assessments, like cognitive, speech, hearing ability, would the information across those different types of assessments, having that information be sufficient to determine ability to communicate effectively, like a global assessment, or would it be helpful to have a data element that pulls together information across the various assessments to provide an overall global basic, like an example, yes, no, this patient is able to communicate effectively? Would you rather have like a global, like, yes, no, this patient can communicate effectively, or would you rather have, in addition to all the individual assessments that would impact communication, or is it sufficient to have the individual assessment results to be able to make that decision yourself?
But this is Bob. I'm going to just jump in and toss a couple of thoughts. If I understand your question, If they say yes, no, and the answer is
Mhm.
yes, they can communicate, but we still don't know if they communicate by sign language versus verbal. It doesn't give us as a clinician a lot of additional information. In other words, we still have to figure out how they communicate.
Yeah.
So from that
Yeah.
aspect, I do think that there's value in having the additional information available.
Yeah, it would still be available. This data element isn't requesting that communication that other data elements related to how they communicate be removed. This is just in addition to all those that information.
Uba, is sign language listed under preferred language?
I don't know.
Because to be honest, that's where I would put it.
Yeah, I'll have to check on that. My computer's down, so I'll have to take a look when I
Or it could
when
be or it could be a two-prong approach, doing the yes and
Mhm.
no, as you mentioned, under patient communication, because this really is about can they effectively communicate, rather than
Mhm.
like let's go into the need to address a clinical limitation and appropriate intervention. And then
Mhm.
what is the preferred language? Just like you would do if someone was speaking Cantonese, for example, right? So there you would click perhaps no, that they have issues with patient communication status. And then when you go on the preferred language, you would see that it has defaulted to or indicated Cantonese. So,
Yeah.
but I don't know the answer to sign language. I don't know if it's in there. I just thought about that.
Yeah. I'll take a look. That's a good example of how a data element like the one that's being proposed here could work, where you have that yes no and then have the other information. If it is no, that other information is available to tell you what those limitations are. So I guess in summary, it seems like lots of folks feel like this one would not be ready, would not be good to move ahead on for submission. Is that, do you all agree on that?
This is Terry.
Mhm.
I would worry less about where it ends up finding its place in USCDI rather than just getting it in the door and putting it anywhere. Doesn't really matter where it ends up. So if you think this is a valuable element, I would get it in there no matter where you think it's going to go. Because they shuffle around all the time anyway. So not to worry.
Okay.
So it's a valuable piece of information, certainly kind of fundamental stuff.
Okay. So I guess the big thing then, if we take out moving it to patient demographics, the other major thing about this is moving it from USCDI level, or from level 0 to USCDI V6. Do you feel like this information would be good to move from level 0 to USCDI V6? So like you said, Terry, this is important information to have. So
Yes.
Yeah.
One vote.
I agree too.
I agree as well.
Okay. Does anybody disagree? Okay, and then in terms of,
we should go for the gusto. They can only say no.
All good. So then in terms of like changing the name, taking out status and just calling it patient communication, does anybody disagree with that? Okay, so we only have 2 minutes left. Yolanda, do you want me to stop here and continue during the
We
next
have
meeting?
until 3.
Oh, until 3. Oh my gosh, sorry.
Yeah. Yeah, I think Maria put a comment in she doesn't think like skip from 1 to USCDI V6 is feasible or is like a
Okay. What would be more feasible?
move to level 1, right? It's a Maria, I'm just speaking for you. You can just go off mute.
No, I believe me, when I first started with this whole process, I wanted to lift everything up from level 0 and just get it done. But it is my understanding that you can ask for whatever you want, but it would be an extreme break in protocol and process, which I don't really see happening under these stormy administrative moments. In suggesting that a data element be promoted from level 0 to USCDI, I think if it's something that's important, we should follow the framework and the process, and we should justify why it should be moved to level 1, and then we go back after it and we move it to level 2. I think we lose traction when we ask for things that can't happen, and we gain traction when we work within the established frameworks.
Yeah, thank you for that. So then the recommendation would be to revise the recommendation to moving it to level 1 and using the framework requirements for having level 1 status as the way that we frame the recommendation. Is that correct?
I really think that is more feasible. And, we have a loud voice within USCDI. PACIO has gained a tremendous amount of respect. And we just, they listen to what we say. Let us not chip away at the pillars of respect by asking for something that we know is not going to happen. You guys, they're not going to take something from level 0 and promote it to USCDI V6. They're just not. So let's proceed within the framework and maintain that era of respect and an understanding of the process. You can say break the rules. Go ahead and break the rules. Jettison it all the way to the top. And if they do it for us, they're going to have to do it for someone else, which means no, they're not going to do it for us. So I think we need to think about this.
Okay, thank you, Maria. So for right now, we can hold on this recommendation to make updates and bring it back to the community. Does that sound okay, Yolanda?
Yeah, absolutely. Do we have additional? Okay, that's so Wuba, do we want to continue review the medical device data class? If you're talking, you're on mute.
Sorry about that. I was on mute. Yeah, so we can move on to, let's see here. Sorry, I lost my place in the document. We'll move on to the medical device data class, device use data element. And so the recommendation is to advance device use to USCDI V6, and currently it's level 2. And this recommendation aligns with recommendations provided by CMS, as well as the Academy of Nutrition and Dietetics, and that is a critical piece of information to share. And so device data right now is already being captured in various assessments, including the FACI. So this information is already being collected, and it provides additional information that is not currently being captured in the unique device identifier data element that is more focused towards implantable devices. So yeah, so does anybody not agree with the way that it's written currently? Okay. Let's go to the next one. This is the order data class, and the nutrition order data class. So here the recommendation is to move it to level 2. And this is important information to be collected. It's already being collected in various different settings. And this is, as I mentioned before, the PACIO community has already addressed nutrition order through developing a profile within the PFE SQ2, specifically on nutrition orders. So there is an IG that's going to be published soon that includes, that supports transmitting this information. So does anybody have any observations about the way this one is written? Okay, so let's move on to the next one. Oh, sorry, my device timed out. Hold on a second.
Yeah, the next one,
Okay,
Uba, is the one where I have
yeah.
alternate language. So I don't know if you want to
Yeah.
review that now or if you want to
Oh, yeah,
wait. We get the alternate
yeah,
language.
yeah. Yes, we will wait. We'll move on. We'll move past the portable medical order related data elements and move, and also the provenance one. So then we'll scroll down to the coordination of comments for allergies and intolerances area. So we'll first look at the criticality data element. This is when the CMS proposed comment is to add the criticality data element to the final USCDI v6, and that this is an important information about allergies that is needed to be able to share. Does anybody have any reservations about how things are described right now? Okay, so we can move to the next one. This is the drug class data element. This one here is adding a vocabulary to this data element. And specifically, it is a data element or a vocabulary that is the med RT. And this is created by the VA and is inclusive of various different terminologies, and that this is important information to communicate and is supported by, maintained by the National Committee on Vital and Health Statistics, and incorporates ARC-Norm, MESH, and SNOMED CT. So does anybody have any comments, or does anybody disagree with how things are written here? Okay, we can move on to the next one. So next one is the, this is for the same, for the drug class allergy intolerance. The recommendation is to reference MedRT, and so this here is the PACIO related comment. The previous one was by CMS, and this one here provides some information about that this data element includes information that's important to share because it incorporates ARC-Norm, MESH, and SNOMED CT. Does anybody have any comments about or any reservations about the PACIO specific comment? Okay, so we can move on to the medication administration code, administration dose, and reason reference data elements. And the CMS proposed comment is recommending to advance these from level 2 to US CDI v6. The rationale is that various organizations, including CMS and CDC, request that these be included to US CDI v6 and to fill critical gaps in patient safety and care quality. And this is information especially critical in PAC settings, and is supported by CMS. Does anybody have any reservations for this recommendation as written? Okay, and then the final thing is, oh yes, yes.
Okay, PACIO is not commenting on this item though, just CMS, correct? PACIO reviewed this one and didn't have any recommended changes. The CMS comments as written were written in coordination with folks on the PACIO team. So PACIO indirectly has contributed to this, but the PACIO community itself doesn't have anything different based on comments we've gotten previously that to have this any different. Okay, thank you.
Yeah, no problem. And the same thing is for the next one, for the medication administration patient data element. This is the last one to review. This one, the person who received, this data element is for the person who received the administrative medication, and the recommendation is to move it from level 2 to US CDI v6. And the recommendation from CMS is because it's necessary information to help differentiate between active, ordered, or administered medication. Does anybody have any reservations about this as written?
So is this one a level 1?
This one is level 2 right now.
Oh, because the recommendation is to advance to level 2.
Oh, oh, interesting. Okay, so we'd have to.
Okay, yeah, I'll reconcile those and bring them back to the committee next week to make sure that everything is aligned.
Okay.
Thank you for that catch.
Yeah, no, I was just reading what was there, because if it's not at level 2, then we got to bring it to level 2. I know, hit rewind, hit play on the cassette player, but we can't jump stair steps.
Yeah, got it. Yeah, thank you so much. Okay, yeah, I will reconcile those and bring them back. So overall, seems like everybody agrees with how things are written, except for these medication data classes, the communication and the communication status data element. For all the other, so we will not vote on those data elements, and we also skipped ADI related, portable medical order related, and provenance related data elements. So we're not voting on that. So just to be clear, based on what everybody has, the feedback that everyone has provided, that there is agreement amongst the community that these data elements are good as is. So that is the functional status and mental cognitive status data elements, the functional status, health concerns, and mental cognitive status data elements recommendations. Those recommendations are both for ICF, including ICF, and where was it? Oh my gosh, I'm losing my place, sorry. For including the ASHA FCM with LID codes. And then the nutrition status data element and the device use data element, nutrition order data element, the allergies and the criticality for allergies and intolerance data element, and the drug class allergy and intolerance data element. All of those had no comments, but I'd like to vote on approving those for submission. Does anybody second that?
I was second that.
Okay. Does anybody abstain from voting?
I don't want to rock the boat. I don't think MITRE can bring forward a vote and second it without a PACIO community person adding their way. I think that's a break in protocol. And I just wonder if we've clearly subset the items that we're voting on, or if there's enough change needed that we don't need to vote next week. That's up to you guys, but I've been trying to pay close attention, and I got to confess, I'm murky.
Oh, okay. If it's okay, Yolanda, can we hold off on voting until next week then, so that I can make updates to all the data elements that were flagged, indicate in the document which ones had no previous comments, and send it to the community for review again?
That would be great. I think, yeah, that's a good point, Maria. And I don't know, two MITRE person cannot do their voting process, but it's good to learn. I think it's next week we can do a summary about the data elements we all agree upon and vote for that. And additionally, we want to share additional information for the community review for their data elements of the classes under discussion.
Okay, great. And I will send it all to the community via the email list that we have for the invitations for the calendar invite. if you currently aren't on the calendar invite because somebody forwarded you the invite, please send us an email and we can add you to the calendar invite, and then I can make sure that when I send out the updated document that it that you'll get that document as well. So my email is UB as in Bravo, A, C as in Charlie, A, O, N as in November, J, A, at miter.org. Yeah, so watch out for that from me, either at the end of this week or early next week. And then if anybody has any comments that you want to send to me in writing, feel free to do that as well. I appreciate any kind of comment in any type of way, and am very grateful for all the comments that you have given so far today, and look forward to more next week. So thank you all so much.
Thank you so much, Wuba.
Yeah, you're welcome.
For leading the discussion. So yeah, we have a long meeting. It's almost 1 hour and a half. But anything else? Any walk-on topics we want to talk as a community? All right, here none. Thank you all again very much for your contribution, and this is invaluable inputs, and we are looking for, and we look forward to seeing you continue on other PACIO community, and we'll see you next week, and have a enjoy the rest of your day. Thank you all. Bye.
Thank you.
Thanks.